Good morning and welcome to the 18th meeting of the Health and Sport Committee in 2019. Can I ask everyone in the room please to ensure that mobiles are switched off or to silent? It is acceptable to use mobile devices for social media purposes, but please do not take photographs or record proceedings. I have apologies from Alec Cole-Hamilton. He will join us very soon, but is not able to be here for the commencement of the meeting. Can I welcome to the committee also Edward Mountain, who is not a member, but a member for the Highlands and Islands region. Welcome, Edward. The first item on the agenda is an evidence session from NHS Highland. This is part of a series that the committee has held with territorial boards from across Scotland. So let me welcome to the committee Boyd Robertson, the chair, Ian Stewart, the chief executive, David Park, chief officer, David Garden, interim director of finance, Boyd Peters, medical director, and George Morrison, Deputy Chief Officer, Argyll and Bute Health and Social Care Partnership. Welcome. Can I start? It will perhaps not surprise anyone that we start with the issue of bullying. That has been very much the headline issue affecting NHS Ireland in the recent past. And can I start simply by asking for a report on where current levels of bullying stand within the board? Ian Stewart.
Thank you. NHS Highland absolutely accept the findings of the Sturrock report, and NHS Highland will not accept or tolerate any bullying. We have started engagement events throughout NHS Highland with all our workforce, travelling from Caithness in the north to Argyll and Bute in the south. And we have set up a draft action plan that is a skeleton of a plan going forward, but it's very important that this plan becomes a plan that is developed with our people, with our staff. And that's the most essential thing. Our plan looks at our communications and engagement with our staff. It looks at our organisational development, our workforce development. It looks at our HR processes. It looks at supporting our staff who have been bullied, and it also looks at the governance within the organisation. So we're pulling together a plan that looks at all these issues.
Thank you very much. David Stewart.
Thank you, Convener. Can I also echo your welcome to Highland Health Board today, and perhaps also recognise that we have had quite a change in leadership since the whole bullying saga kicked off. But particularly, there's a number of members. I won't mention them all, but obviously Ian Stewart's the new chief exec, and Boyd Robertson, interim chair, who I knew well from summer days. So welcome, gentlemen, to your new post. You'll know that Highland Health Board is my home board, and I've been dealing with the board for 20 years in 2 different parliaments. And along with colleagues like Edward Mountain, I have to say I probably was the most shocked I ever was at a meeting in Eden Court when over 60 people turned up. I thought I knew a little bit about in casework on issues affecting Highland Health Board, but I was genuinely shocked by the number of people raising issues of bullying and a whole variety of strata of the organisation. So the first issue I really want to raise is there going to be a scheme for psychological counselling of staff who've been bullied, and some of them, of course, have seen their careers ruined and are now unable to work?
Ian Stewart.
Yes, so one of the work streams we have in our action plan is looking at supporting our people who have been bullied. So we're looking at various ways of supporting them. We're looking at counselling, we are looking at mediation, we are looking at support. We have an occupational health department, etc. So we have been hearing also about the bad stories. Both the chairman and myself have welcomed our colleagues to come in and speak to us and listen to the harm that has been caused, and there has been some harm caused, but we absolutely will be supporting these people, you know, as much as we can, without a doubt. That includes psychological help. It includes, as I say, bringing different colleagues together to support them.
And the second issue, through your convener, is the issue of compensation. Again, I'm sure, like Edward Mountain, my mailbag's been really full with cases who've approached me who say their careers have been ruined and they have lost out financially. Is there any scheme of compensation that the board are looking at to try and help these staff who really have seen their careers blighted in many ways and are able to work? Obviously, for confidentiality reasons, I can't quote these cases today on their request, but I've had numerous cases directly about this, and I'm obviously highly concerned about the effect it's had on their career, and they're still, the bulk of them stay still within the Highland Health Board area.
Boyd Robertson.
We are aware of these cases. I have met personally with a number of these people, and so has Ian as Chief Executive. And we are working through the recommendations of the Sturrock report. We had a retreat last week, or a strategy workshop to be exact, as recommended by John Sturrock, to look deeper at the issues in his report and his recommendations. And one of the areas we will be looking at is the area of compensation, but we're not yet at a stage where we can give a definitive answer as to how we're going to deal with that.
Okay. If I move to another area, clearly it's important to look at the issue of whistleblowing champions. I was obviously concerned that the champion resigned after 2 months in the job without again breaching confidentiality. Is there any particular reasons for that? We've described previously the culture in the board being toxic, albeit under a different regime. Did that toxic climate affect the whistleblowing champion?
Ian Stewart.
I don't believe so. We have very quickly taken on a new whistleblowing champion, which is one of our new non-exec directors, Jean Boardman. So we're very pleased Jean was willing to take up that post.
And have you any comments about the premature resignation? I mean, 2 months is not a long time to have in post.
The non-exec in post, was in post for a period before that, and I've been given no information of why she resigned from the post, I'm afraid.
And I suppose in wider terms, so you can be in it, this is obviously the most important issue facing the board. I mean, I'm obviously very concerned, as all of you are, about attracting able staff from the rest of Scotland, indeed the UK, to come and work in Highland Health Board. Clearly, when we talk on finance, we raise the issue of the expense of locums and how difficult it is sometimes with retention. This is clearly a major issue for attraction of staff and retention of staff. What is the board's thoughts on that? And I understand in previous meetings that you have strengthened the HR component of the board. That seemed, from an outside perspective, a fairly straightforward next step. What are you going to do to strengthen HR and strengthen the culture to make sure people want to work for the board and want to continue working for the board?
The first things we had to do was ensure that our senior leadership team was strong and in place, and that's what we are currently working on. As you say, we have got a new HR director who started just a month ago. We have a new medical director that has, again, in the last month just started. But with regard to HR, we absolutely need to strengthen our HR processes, and we are working with NHS Scotland on the Once for Scotland HR processes that we're looking forward to. We believe that's a sensible way forward, and we have asked our HR director to look at the structure within the HR department to ensure that we have got a structure that makes us equipped for the future ahead of NHS Highland. And as you say, I am absolutely adamant, as we talk about the culture in NHS Highland, we do want NHS Highland to be an absolute place of choice for people to work in the Highlands and in Scotland. We want to attract the best people that we can to work in NHS Highland, and that's what we absolutely intend to do. And we intend to do that, number one, by changing the culture in the organisation, and that's something both the chair, myself and the senior leadership team are determined to do. And we believe so far that there are green shoots in the culture changing. We get good reports from various places that the culture is changing. We had an iMatter survey with our staff, and this is the first time I think we've ever had a response back of 60% and over. Out of, I believe, 33 metrics, the metrics are based on red, amber, yellow and green, and we only had 4 yellows. We had no ambers and no reds. But one of the yellows was to do with visible leadership. And that's one thing we're determined to do, that the chair and I and the senior leadership team work across the whole of the Highlands, or Guyland Buttes, to speak to all our people so that they get to know us and we get to know them. And I think that is really important, and that is absolutely the first thing we do. It's by communications, engagement and our people.
And I'm sure that the message will come from all my colleagues in the committee. I suppose the most general point that bullying is not acceptable anywhere in society, in the public sector or the private sector. And really, in my simple terms, it would be about abuse of power. But clearly, it's easier to do that in more senior levels to more junior staff. So I'm sure the message, Mr. Stewart and Mr. Robertson, you're putting out is that abuse of power is not accepted in any level of your organisation, and that Highlands are a good place to work. But we've got to get this right.
We want to make Highlands the best place to work, and bullying is absolutely not tolerated in NHS Highland.
We have apologised twice publicly for the behaviour that preceded this the Sturrock report. But we are conscious that bullying takes some time to stop, and therefore we have to have ways of checking and having early intervention in situations where we know that there's unacceptable behaviour.
Thank you, Convener.
Emma Harper.
Thank you, Convener. I'm interested in what you've said, Ian Stewart, about the new HR Director will be focusing, I'm sure, on prioritising communication, engagement and people. And you've just said that the iMatter survey is now 60% or 61%?
Of our staff responded, and that's the first time that we've had such a high response to iMatter.
Okay, and so in our papers we received information that the iMatters surveys were below what was acceptable to be part of the national consideration for feedback. So I'm interested to know what you did different then to engage the staff to actually participate in the iMatter survey.
So in order to get feedback from iMatter, you require 60%, and we achieved the 60% this year. We communicated a lot with staff, let staff know how important it was to give feedback, because staff must realise that in order for us to be able to help make the future better, we must know what we need to change. And it's important that we hear from the staff so that we know how we can change. And that's very much the reason that we are visiting all our workforce throughout the Highlands, so that we can understand from them face to face what issues they face and how we can make NHS Highland a better place to work in.
And I'm interested in the change management methodology. I mean, when people are seeing that changes is happening and sometimes they feel it's imposed upon them rather than working with them. So, and I understand as a former NHS employee myself that it's a very high pressured environment to engage in staff, and now we've got a health and social care integration that's upon us as well. So as part of that adaptation to change is identifying who are the change agents, who are the early adopters, and how we can help work with people who maybe aren't as easy to adapt to change.
And what we are doing as an organisation, as I said, we're visiting and having workshops with all our staff throughout NHS Highland, and there are non-exec directors and directors who are part of that workshops. So I believe it's on Friday, I believe we are visiting Caithness this week, we are visiting down south to Argyll and Bute, Skye. We've already held 3 events in Inverness where people come to an event and they talk to the executives and non-executives directly, and we listen to them. And what I found from that, which is really good, that people are coming up to us and who take part in the event and said, how can I be part of this going forward? I want to work with you in developing a different culture in the organisation. There's people coming up to us and offering their support to do that.
Okay.
Thank you very much. Brian Whittle.
Thank you, Convener. If I may, I think there was something quite important within the bullying aspect of it that is missed, if I could. Good morning to the panel. You talked to my colleague Dave Stewart there around your interventions with those who have reported having been bullied. What interventions have you done for those who perpetrated the bullying in the first place, and what sanctions or training has been put in place to help them?
So we need to take each case by case, and allegations of bullying and investigations into these allegations are ongoing, and we will work through the HR process. But what we want to ensure is that we don't go straight to an HR process. I think that's really important, and that's one thing we have learned from the John Sturrock report, is that we shouldn't necessarily go straight there. We should look at things like mediation, etc. Look at how we can pull people together to let them know, to let us work together on an understanding of what has happened, why it's happened, how it's made people feel, etc., etc. So it's not about going straight down the HR disciplinary route. It's about working out what is the best way to deal with individual cases. But if there is bullying that occurs and we have to go down the HR process, then we absolutely will and will do that, and we are doing that at the moment. But it's also looking at other ways of dealing with this.
Isn't mediation an HR process?
It is an HR process, but what we're wanting to look at, not only internal mediation, but external mediation, how people may feel more comfortable with external mediation as well.
Okay.
I will come on to this other subject about recruitment and retention later on, but I just wanted to ask you a question. when you're speaking to staff, has the bullying had any effect on retaining staff and actually basically getting staff there as well? Has that had an effect on the staffing and the recruitment and retention of staff?
Yeah, I think I don't know how many posts have been affected, etc., by that. But within NHS Highland, there are lots of reasons for having difficulty with the recruitment and retention. The geography of the Highlands, for one, etc. There are many issues we're facing with regard to recruitment and retention, things like housing, the rurality. But
I mean, I'm hoping to, go on to that question. It was just specifically the bullying when people, leave, etc. Do they cite the fact that the bullying, or they've heard about bullying, that's why you can't retain staff, or you can't recruit them? It's just a simple yes or no, I think.
we have had correspondence and discussions with people who have left, who have said they have left and retired because of bullying. That has absolutely happened, yes. We don't know the specific numbers, for that.
Thank you.
In that category, and there are also perpetrators who have left the organisation as well.
Okay, thank you very much. Before we move on from Sturrock, I wonder if Alec Cole-Hamilton had a supplementary on that area.
I think a lot of it has actually been covered by my colleagues' community, so I'd like to keep my time for the other things, the specifics I'd like to cover later on in the meeting. My apologies for my late arrival.
We'll come back to those later. I'm very conscious that thus far we have heard only from the Chair and the Chief Executive. I'm conscious also that we have an all-male panel, which is unusual in this day and age. I would ask if any of the other witnesses have things they would like to add before we move on from Sturrock, because clearly that has set the context for everybody's work in NHS Highland in the recent past. David Park.
Yes, if I just may add to the last question that was asked. We recognise that our staff are one of our greatest selling points and actually the facilitators of recruitment. I haven't heard specifically back to me that somebody has, in recent times, resigned because of bullying. But it has undoubtedly affected morale. And it makes it more difficult to do that positive sell about the organisation that so many people are proud of. And there is a strong will within the organisation and within the people that work within it to be able to restore the reputation and be proud again of the place that they work, and ultimately about the care that they ultimately deliver. And that in a local sense, what the feedback they receive from patients or clients, depending on who they're caring for, still exists. And still they get that positive feedback, but there's no doubt that this has created a cloud that hangs over us, and there is a determination to move forward and to restore that reputation.
Thank you very much. I'll move on to finance. Brian Whittle.
Thank you again, Convener. Yeah, I think one of the other things we need to look at quite closely here is the current situation with the board's financial position. I mean, you required brokerage last year to the tune of 18 million. I think that's the second year in a row, and you currently sit at a level 4 on the Scottish Government's escalation framework, which has required a number of interventions, which includes external consultancy. So I just wonder, firstly, can I ask you what level of brokerage the board expects to require in the coming years?
So this year we expect brokerage will be requiring approximately 11 million, and the next year 8 million, and we hope to break even in the third year.
Okay. The Cabinet Secretary has made a commitment to write off the board's debt, and I wondered, is that brokerage that you've just talked about there, is that included within that commitment from the Cabinet Secretary?
No, we at this moment, with regard to the 11 million for this year and 8 million for the year after, we don't know whether that will be settled or not. But we fully accept that if it is not, that we fully accept that we may be required to pay that back in coming years.
So, where are the key cost pressures then that are currently sitting the board that year on year requiring this kind of brokerage?
Medical staffing, especially locum medical staffing, drugs, and also social care. That's our three main overspending areas.
And you're suggesting there that you fully expect to have to pay that excess brokerage back. How is that going to impact on service?
Well, we hope that in coming years, that when we manage to come in to financial balance, that non-recurrent fundings will help us pay back that in year 3. But my colleague Dave Garden will be able to give more details on that.
Yes, thank you. We fully expect to have to repay our brokerage once we're back into financial balance. Whilst we haven't actually factored that into our plans right now, because it'll come after year 3, what we're expecting is every year there are fortuitous non-recurring benefits that materialise during the year. And what we'd expect is to, rather than dig deeper in terms of finding recurrent savings to pay off brokerage, which is a temporary payment, if you like, of a loan, for want of a better word, what we'll use is any non-recurring benefits to pay that back over a period of time that we need to agree with government.
What plans do you have currently? Do you have in place to get to that break-even point in the first place and to be able to pay that brokerage back?
So, it's okay, yeah. So just to let you know, this year we have had very welcome assistance from PwC, who have come in for 6 months, who helped us set up our own programme management office. Now that has helped us greatly. Their time with us has now ended, and we are now set up our own programme management office within NHS Highland. This is the first time that we've had this in recent years, and we have built up a team that will help us deliver this. So this year we hope savings of 28 million. When we look at the schemes that are going through our system at the moment, they are to the value of 30 million. That is unrisk adjusted. When we risk adjust it so far, it leaves us a £23 million saving anticipated this year, with still, several months of the year left. So we do want to get up to 28 million. So we hope to raise another £5 million worth of saving this year. So we believe that we are on target to this. There are other cost pressures, of course, that we have, as we talked about, medical staffing, locum staffing, but also that doesn't take account of our non-recurring costs. So we've still got non-recurring savings on top of that to help us. So just to summarise, 28 target this year, unrisk adjusted 30 million we believe achieved, risk adjusted down to 23 million, with a 5 million gap to find in savings this year.
Just to finish, just to clarify, are you on a 3-year plan to break even? Is that
3-year plan? Yes. So we'll break even on year 3. That is our aim.
Thank you.
But just to be clear, when you talk about a 5 million gap of as yet identified savings, that's in addition to the 11 million brokerage. So it's effectively a gap of 16 million.
Absolutely, yes.
Yeah, for this current year. Okay, thank you very much. David Stewart.
Thank you, Camille. Could I raise, hopefully, a more positive aspect to the financing, and that's the spending to save issue. Mr Stewart will be aware of my sort of local campaign to try and have a PET scanner placed in Inverness, perhaps the Centre of Health Science. And for those that were off school that day, that's the positron emission tomography, obviously used in diagnosis of cancer. I did some parliamentary questions on this and found that 400 Highland patients went to PET scanning in the Central Belt at a cost of 400,000 a year. Now, clearly there's on-cost for capital and extra staff, but I'm a great believer in the decentralisation of health whenever we can. I've had a discussion with Mr Stewart about this issue. I think this would be a huge development for the Highlands, and just wondered if Mr Stewart could give the committee an update on whether this is a possibility. I've also raised it with the Cabinet Secretary as well.
Yes. So you're quite right. We believe roughly about one patient per day, roughly about 350, 400 that could take advantage of a PET scanner in the Highlands. The PET scanners are distributed. I believe there's 5 currently in Scotland, 2 in Glasgow, 1 in Edinburgh, 1 in Dundee, 1 in Aberdeen. They are actually distributed centrally by NHS Scotland, and I'm quite sure they will be looking at the needs of the whole population and where that should be located. But certainly, any extra facility to the Highlands will be very much appreciated.
And just finally, I don't want to go into too much detail at this stage. The other key point, which is a very obvious one, is it's not just beneficially financially, it's beneficial for patients in Highlands and Islands because we're reducing travel costs and we're reducing inconvenience for patients. Because bear in mind, it's relatively a huge health board geographic area. And I'm not looking for a reply for my next point, but one that I'm sure you will look at. There's obviously supply issues to PET scanners in terms of radiopharmaceuticals. Perhaps you can do a little bit more work around the provision of cyclotron, which is the provision of raw materials which we have from Aberdeen, Dundee and Glasgow. There's particular issues post-Brexit on this I won't bore you with, but I think this is really important to look at the thought process behind it. But I would emphasise the Centre for Health Science has got some, you'll be well aware of this, has got great opportunities to provide a home for a future PET scanner.
That's noted. Thank you very much. Miles Briggs.
Thank you and good morning to the panel. I wanted to carry on the financial aspect before moving on to other things with regards to some of the evidence which had been submitted by the board, and particularly looking at new medicine costs. And I know this has already been mentioned, but it was interesting in terms of the evidence which you submitted pointed towards potential cost containment around new medicines. And looking at the detail you provided, the actual spend on new medicines was just £34,621. So I was wondering if you could explain, and it'd be useful to understand, how the statement in the report matches the financial figures which was provided.
Boyd Peters.
Yeah, thanks. A good start for me. I don't actually know what the answer to that is. There are, every health board has a large number of new medicines coming on stream. Some of the uptake of that depends on the specialists involved in the specialist treatment. Some of the data that's supplied will depend on what's classified as new, because some of the new things, once have been around for so many years, they're not so new. They're more mainstream. So without knowing the specifics of what was submitted, it's difficult to comment precisely. We do have to have systems in place to consider new things so that they're applied in line with NHS Scotland policy. And I don't think we're an extreme outlier in any of the usual forms of prescribing.
You can maybe, following the meeting, write to us in your own time. It's maybe just a typing error, I don't know, but it seemed a very low figure when I looked at the evidence admitted. Looking at overall board performance, I wondered, in terms of mental health services, it's clearly a challenge across Scotland, but particularly in Highland, with targets not being met. And I just wondered, in terms of the additional resources which have been made available, what the health board's doing to take forward reform of CAMS particularly, but mental health services more generally across the health board.
Yes, I'll take that. Yeah, so there has been additional investment particularly in psychological therapies, both for children and adolescents, as you mentioned, and also adult services. I think there's a national challenge, and I think most health boards are trying to achieve the government set targets. NHS Highland is working within that framework, and we're committed to improving our stats, which were reasonable and in line with many other boards, but which naturally have room for improvement still.
Is anyone?
No, sorry. No.
And I think it was in April that Edward Mountain and I visited Regmore, and thank you for kindly setting up that visit for me. And I was impressed by all the NHS staff who I met, but I know the challenges you outlined in terms of a rural board attracting people. Now, that's something we've had many conversations as a committee about, and I wondered, in terms of really looking to the future to attract NHS workers, what innovations do you think are needed, or what have you been able to take forward, not only in retaining staff, but trying to attract new people to Highland? I know particularly with new graduates, and you outlined this to me, lots of new graduates come to do their initial training but then leave. So in terms of what more can be done and what more national government has to do, is there anything you'd like to outline today around that?
Yes, so there is lots we're doing. Can I give you one example about Rathsay and Skye? So Rathsay and Skye is a very rural part of the Highlands, and they require to have a nurse. So we work together with the community, on pulling together advertisements, etc., and working with the local community requirements, i.e. with regard to distillery and recruitment there. So we work together with them to have a campaign in order to attract not only NHS people, but other workforces to the island. And we do this also together with the Highland Council, so that we can come together as a group and that we can recruit not only individuals but families to the Highlands. I think that's really important. And we have an absolutely outstanding number of people applying for the post. David, I believe we had
27 actually. So I think in a broader way, that there isn't a single solution to the recruitment issues. And you have to look at it from a skill set point of view as to which skill set that you're trying to recruit to, as well as location. And each location, as I say, for Rassay or Skye and Lacalsh versus Caithness, it can actually be different challenges that you're looking at. So actually involving local communities and local interested parties, local councils, and actually local employers, as we did in Skye, is a really good way to look and say we're actually trying to attract families to a community. So how do we make that easier for them to move to a community? Because it's typically not one spouse, for example, or one partner that is being attracted to a job. But if you're trying to bring people into a location, you need to think of the family setup. You might need to think of the other spouse in terms of work. And when we post our roles, we tend to do that on an individual basis, whereas looking at it this way, it does two things. It allows us to look at attracting a family. Secondly, we recognise that, as I mentioned earlier, we each have different selling points in terms of what can attract people to a locality. It could be the spouse's job, not necessarily within the NHS. It might be the NHS role is the draw, and somebody else is still needing a job as a teacher or whatever that may be. So combining those ideas and combining the opportunity that can be created. We've done it in one small part so far, but I definitely think that is an opportunity going forward.
And then Ian Stewart.
Thank you, and we did talk about this when you visited. It's a very broad question with a broad answer. It's clear that scenery isn't the attractive bit. It's actually other things such as the job conditions, research, availability of research, education. And one of our conversations, as you'll remember, was around the deaneries and universities placing students or postgrad doctors and other staff within the likes of the Highlands, so that people experience delivering care in that environment, and it's up to us to provide a good experience for them when they come. But the allocation of people to places such as Inverness needs to be looked at. There also needs to be a national drive in terms of the sort of development, the education of people into nursing and medical workforce. We have some serious workforce challenges nationally, which it's a bit of a time bomb. We're beginning to see that time bomb explode, and we will need an increased number of these staff groups over the next decade. In fact, we could do with them immediately in some cases. So it's very broad. We're looking at things regionally for solutions for some of the specialist type services. We're also thinking about flexible job planning and job arrangements. People nowadays work differently, and sort of the way that families run themselves is different. The parental involvement in their children, the hours that they work and so on, and we need to flex with that as well. So it requires a lot of innovation at all levels, regional and national, as well as local, and definitely within education. And the final plea would be that we do, and you as well could do what you can to promote those who are in schools, for instance in the Highlands, to be helped into the education that I've mentioned, and hopefully some of them will come back in due course to be the next doctors and nurses and physiotherapists that we need in the Highlands.
Ian Stewart.
Another issue there is in the Highlands is housing. So if we go back to Skye and Rathsay, housing is absolutely an issue when it comes to attracting staff. But what we have done, for instance, in Rothsay, is work with Lochallach and Skye Housing Association so that we can provide housing for these staff. So again, it's about working with partners to ensure that we can attract the right people. Just like you know as well, one thing that we've done in the Highlands is look at midwives. There is a shortage of midwives in the Highlands. And within the Highlands, it's the second year now, we've brought in an accelerated midwife course. So currently qualified nurses can be trained to become midwives within 20 months. And this is attracting, nurses from all over the Highlands and Islands to come and become midwives. Because we do have a need for midwives, and this is an accelerated course that will assist us with that. So, as Boyd said, it's about thinking innovatively about how we can do things, but it's also about looking at our professional range of people. Can we use advanced nurse practitioners rather than another professional? So it's all about looking at the development of existing staff in order to step up and do other roles, which we're very keen on and have to do.
Thank you very much. I wonder, George Morrison, if there's anything to add here in relation to Argyll and Bute.
Not a great deal to add, to be honest. I think all the comments that my colleagues have mentioned there are relevant in Argyll and Bute. We've got the same issues. We've got an ageing workforce. We've got difficulties in recruitment and retention. Housing in certain areas is also an issue. It's very common themes, and we follow the lead from the board in trying to address these matters.
Brian Whittle.
Just looking at the performance figures, what kind of stood out for me was the cancer treatment performance, especially around the treatment time guarantee. Not unique to Highland Islands, I would suggest, and certainly not to an area of such rurality. And I wondered what thought had been given to how you will close that treatment time guarantee gap. I know other boards have looked at community-based cancer treatment for those cancers where that is appropriate, and I wonder whether you've considered those sort of any sort of plans around those sort of satellite community areas.
Ian Stewart.
So with regard to our cancer waiting times, the 31-day target, the target for that is 95%. In June we managed 95.6%, which we're very happy with. That's against Scottish average of 94.9%. With regard to the 62-day target, not so good. In June, we achieved 83.6 against a 95% target. So it's 83.6 against a Scottish average of 81.4. Much of our issues are around urology. Urology is an issue not only in NHS Highland, but throughout the whole of Scotland and the UK, because there is a great demand on urology, prostate, etc. So that is... we have had locums in working with that, and things are improving. I don't know, Dave, can you give more details on the cancer?
Yeah, happy to. As Ian mentioned, urology is one of the areas where our fragility is because some of these, the delivery model is with single-handed practice. So in order to flex capacity or to deal with an increased number, the regional agenda is extremely important to us. So our partnership with Grampian in particular, we had recently a consultant move from Highland to Grampian, but they are going to continue to treat patients from Highland in Grampian. And so that's an area that those ties are extremely important when there are so few specialists in that. In terms of the numbers, it's actually quite small numbers in absolute terms. Of course, we want to provide the best care for every patient, but they are relatively low numbers, and therefore the difference between success and failure in that regard is relatively slight. So it's important that we just continue to build on the relationships, and I know that Boyd here has been involved with that North Island cancer programme.
Yeah, there's no easy answer, and I think there's a lot of detail to really answer your question. We're looking at all the various possibilities, and there are a number of different elements of work and effort to try and address TTG. The regional approach is one of many bits of that particular jigsaw. It's something that we're committed to. It's a challenge for all boards at this time, and there are some new variables in the equation as well, which are making it a little bit more difficult than previously. I think you'll be aware of, for instance, the pension and tax issues for senior doctors, which now limits the amount of extra time they'll commit to this work, which is often additional work that we do. So there are challenges in meeting TTG, and these some are actually national as well as local.
These targets are targets, and they're there to be met. I think an earlier answer on CAMS suggested that, well, it was no great surprise that we couldn't meet them, but I wonder, have you ever met CAMS targets, or have you an idea of when you might meet that target?
I don't think we have a projection of when, but and the other thing about, and again, CAMS is a national sort of challenge as well. What we are noticing nationally as well as locally is that the number of referrals is increasing year on year into CAMS. So I used to be a GP, and 10 or 15 years ago, the number of referrals were much lower from the community. In the last decade, the referral rate has rocketed for CAMS and also for other psychological therapies. And that means that we're, in a sense, playing catch-up, actually, in terms of we're not just reaching a target that's static, but we're chasing a target that's moving away from us. And so that's an additional challenge. That's why it's difficult to say exactly when we'll arrive there, because the target's moving. And the numbers of referrals are increasing. So, but every effort is being made to do that.
It's bad and getting worse, is really what you're saying.
Well, I think we've closed some of the gap, actually. So I'd like to not phrase it that way. It's challenging. Efforts are being made, but we must be conscious that the challenge is changing.
In Stuart.
Many more referrals for ADHD and behavioural issues as well. That is increasing it. Just like you know, our CAMS performance, the target is certainly 90%. Within the 18 weeks, we're currently at 81.4%. That's against a Scottish average of 73.6%.
Okay. Emma Harper.
Just a couple of quick questions on some of the issues around targets, and it might be that Boyd Peters can help me with this, because I've asked questions before about Staph aureus bacteremias and Clostridium difficile infections. Your targets are almost being met. You know, it's not like you're way off. And because of the numbers of patients in Highlands and Islands Board compared to really urban areas where you might be talking about 1,000 patients versus lower numbers in a rural area, that makes it really challenging to meet targets if your SABs and your C. diff infections are barely off. So what are the challenges then of meeting your Staph aureus bacteremia targets? Because I know it's not just central lines and cannula, it's other issues around abscess and things like that. So there are challenges around meeting these particular C. diff and Staph aureus targets.
Yeah. So if the nurse director was here, she would be able to speak at length about this. And there are great efforts made to address this kind of work. It's very important work. I think our performance is usually very good. But as you say, it just takes a few cases to occur to shift the statistics for us in terms of the percentages, because we have relatively small numbers. It's still high priority, though, and remains so, and every effort is made. Staff clinically in the wards are working hard to keep that as low as possible.
Thank you, Convener. Can I go back to a point that Boyd Peters raised earlier, so it doesn't get lost? The issue about the UK pension provisions and the effect that had on retention recruitment, particularly among doctors and consultants. The panel will be aware that the Secretary of State for Health in Westminster made a statement on this, which basically said that they were going to try and protect the pension provision for doctors and consultants. Now, obviously, this is a reserved issue. It's primarily a Treasury issue around lifetime allowance. I've tried to pursue this. It doesn't appear that anything in Scotland is actually happening on this particular point. I wonder if the panel could cast any light on this particular issue.
So the Scottish Government are certainly making representation to Westminster with regard to this. You know, it is causing us a major issue, and it is causing us an issue with regard to our performance and how quickly we treat our patients. We're estimating approximately our workforce capacity with regard to consultants has reduced by 15% as a consequence of this. This is having a big effect on the care that we can give to our patients, especially around orthopaedics, etc. So it is absolutely an issue. I often get letters from my consultants and other worried colleagues about this. But certainly I do know that colleagues in Edinburgh are making representation to the government. But
thank you for raising the point. It's I appreciate you. It came as a question, but actually I think we are all of like mind. Very glad you raised it personally, but also on behalf of all of the medical workforce that I would represent. We have lots of great doctors, very specialised doctors who want to provide some of the services that my colleague to my right has mentioned for TTG, but they're a little bit hamstrung at the moment because it will cost them. They'll actually be financially penalised to work more just at a time when they want to and we would like them to. So there's a huge issue here, a huge UK issue, but it's affecting Scotland. And while it's a reserved matter, it is nevertheless extremely important to us and the care of our patients. So I'm glad that it's getting the light shone on it today. Thank you.
Stuart.
Both the chair and myself met with Mr Henry MP with regard to this as well, and we have asked that he raise this also in the House of Commons.
Very much. Edward Mountain.
Mine is particularly on the board. If there's a more appropriate time, convener, I'm very happy to wait, or it's not on this subject.
I think it's really performance we're still on, so I think I have Miles Briggs and then Alec O'Hammond.
Thank you, convener. A number of points have already been touched upon, but I wanted to go back to some of the key targets around mental health, because today we've got statistics showing yet again declines across Scotland in terms of CAMHS, and particularly with what was said earlier with regards to NHS staff being able to access mental health support. Given that psychological therapy waiting times for your board, for example, sit at 76.4% against the 18-week on target of 90%. Where are you looking to get extra capacity to try to improve that situation?
So, in terms of adult psychology, we've a lead psychologist who's initially, having come on board less than 2 years ago, she started a review of the entire service because we realised before government prompting that it was something that we wanted to address. Having done that, she's now implementing a whole raft of changes and has brought in some additional staffing as well. Some of the sort of existing sort of client base or patient base is reviewed because actually in some cases the need has changed, or in some cases the referral in the old system that we had was made well-intentioned, but when psychologists assessed the individual, they found that actually specifically the psychology wasn't what was required, but was something else. And so sometimes people are waiting for a while in a system to be assessed to find out that actually they needed something slightly different. We've changed that around to try and take out that delay, and also means that people aren't unnecessarily on lists. And for that reason, in fact, I think my colleague texted me this morning to advise me that we're now at 80%, so we're steadily improving by the looks of it. It's a journey, as ever, and as I say, with adult psychology, the referral rates are also increasing. I think society is more aware and more willing. We're slowly, as a society, destigmatising mental health, and so the referrals are increasing. So one must remember it's a moving target.
Sure, no, I respect that. In terms of rejected referrals, I can't actually see the actual figure within the data we have here. I don't know if you have that to hand. Rejected referrals for CAMHS. Yeah. What sort of work's going on around that? Because I know we've been hearing a lot of evidence given to committee around, in many cases, when a referral is rejected, they end up returning again in crisis. And so what work could take place around that, especially maybe with the third sector, where you have that capacity within Highland?
Yeah, there's always a team approach, and where other available services and therapies can be used, that's followed. I think that it's rejected is maybe not a great term, but sometimes referrals are not appropriate and may not be, with the service that exists, may not be so easily dealt with at that time, or there may not be enough information given in the referral originally to allow the person assessing the referral to understand that there's something that the service will be able to help with. I think, as with other boards, we need to work at that and make sure that we're not turning away anyone that should actually be seen or should actually be referred on to a different type of service. And so it's clearly a very important thing to get right.
And in another area in terms of performance, the beginning of recess, we obviously had drug-related death statistics published. I, again, don't have the figures for Highland in the briefing here, but in terms of any work which you're looking at, given this national emergency, and particularly given a rural island situation as well, what work have you started ahead of the government task force, and have you had any discussions already around that? And key, I think for these discussions is making sure that we take into account rurality being one of the most challenging aspects of this as well.
Yeah, so in my time before medical director, I was Associate Medical Director of Mental Health, and I sat in on our regular meetings where we review every drug-related death to see what lessons can be learned. That's well established, and I would single out Susie Calder for her leadership in that, and it's been very useful. However, I think you allude quite rightly to societal change, and that we are slowly seeing an increase in numbers. We in the Highlands, much of the rurality issue means that there are only a few hotspots, and most areas are clear of drug-related deaths, but there are a few hotspots which I won't name here, but we're aware of those, and some extra work will occur there. Mental health teams, social work teams and primary care teams will be aware and alerted to cases where they are known about. There are always a proportion of these unfortunate deaths which occur, which are uncited by services prior to the sad event occurring, but it is high on our agenda.
Thank you.
Alec Cohan.
Thank you, Convener, and good morning to the panel. My apologies for my late arrival. I'd like to ask particular aspects about provision within NHS Highland, particularly in remote and rural communities. Can I start by asking, since the downgrading of maternity services in the far north, what risk assessment has been carried out for mothers who have to travel 200 miles to Inverness to give birth?
So there has recently been completed an adverse review event. This has been looked at independently, where it was found that it was the right decision to transfer a patient, and that it would not have been the right decision to transfer that patient either by air or keeping that patient in the hospital in Caithness. We look at this constantly, and certainly the evidence that we find constantly is that the method of operating at the moment is the right method, that is best for mother and baby, where they are on a red pathway, i.e. a high-risk pathway, for these patients to be transferred to Regmore Hospital. One of the main reasons for that is that within Regmore Hospital we have a special care baby unit. In Caithness we don't have that, and we must always be concerned about the safety and the well-being of mother and baby. And in these occasions the decisions are made to transfer for their safety. My colleague...
It was probably for me, that one, really. I think the original decision was taken. There had been a number of adverse events a number of years ago, and we don't like to see these happen, particularly where fatality is involved. No fatalities have occurred since the change, and that's a positive. there is still a sort of a local midwife-run unit, which is similar to what we have in other parts of the Highlands. These days, the societal expectation is for 100%, if you like, and the medical and technical need for a baby and mother when they are in crisis, when it's a high-risk birth, is that you have not just the obstetricians available to do the care to the mother and to deliver the baby, but much more importantly, neonatal care, so intensive care for a newly born and sometimes premature and probably unwell baby. That is a very specialised service requiring a specialised facility. In order to minimise risk, then that,
Mr. Peters, I'm not sure you've understood my question. I'm not asking for the reasoning behind the downgrade. I understand the reasoning. What I'm asking for is the resilience and risk planning for pregnant mothers who are in labour, who have to be transferred 200 miles to Regmore. What happens when the A9 is blocked, for example? Give me your contingency planning for that.
Right, got you. Yeah, so number one is the clinicians involved directly will, with the mother, decide where birthing would be appropriate. Should a situation arise it's 120 miles. If a situation arises, for instance, in Caithness, then that would be someone who is thought to be a low risk, or someone who is perhaps presenting prematurely, and so is not yet at a time where they would have a birth. And in these unusual occasions, we have, we make use of Scottish Ambulance Service. If the road's blocked, there is air transport, but we usually would prefer road transport. The number of incidents where this has occurred has been very small.
Have had to be flown to Regmore?
Flying is unusual when you're actually in labour, so it's not usually done.
You answered my question there. What happens when the A9's blocked?
Yes.
And you said we might transfer them by air. So it's unusual and it's not ideal. I'm not getting confidence that there is a proper resilience plan for if that happens.
Yeah, so I think that's why we plan ahead and make sure that any delivery that's likely to be high risk, we make sure that person comes to Inverness before the time of their labour. The problem that we would have, no matter where a person is that some people can go into very premature labour unexpectedly, and that's a challenge that we have to deal with on a case-by-case basis.
Okay, if I can move on to another area of provision. I understand that I've heard of a number of examples of cases in the northwest of Sutherland where home care has not been delivered as expected, where people have been waiting days on end for carers to attend. Can you explain why that is?
So, home care.
I'd be happy to do that. I think it goes back somewhat to our recruitment issue that we described earlier on. Home care, we now have increased the number of hours of provision to around 15,000 hours across Highland. So our home care is provided at a higher level, significantly higher level than it's done before, and that represents the demand that is placed upon us. There are certain areas where, although there are certain areas that are more difficult to recruit to in terms of care home. We use a combination of both in-house provision, that we have our own employees, as well as working with the independent sector. Recently, with the independent sector, we have created incentives for them to expand their capacity, in particular in areas that are more difficult to provide and where there is a waiting time. So we are hopeful that will help us to expand the capacity that's needed in these places.
This is about capacity. It's just that you've not had the workers you needed to fill those shifts in the more remote areas.
Yeah, we're always looking at our processes because they can always be improved and shorten the time, but it's predominantly a capacity issue.
Okay, another area of provision, I promise this will be the last one. I understand that corrective eye surgery is currently on hold because NHS Highland cannot afford the cost of patients being treated in Aberdeen by NHS Grampian. Why is this? And NHS Highland can't perform this kind of surgery?
Which type of... Which...
Corrective eye surgery.
Oh, corrective eye surgery. Right.
Currently don't know of any issue with regard to that, nor the cost, but that's something that we will look into.
Please, and if you could write to the committee.
Thank you very much. I think at the moment I have a note of perhaps if you could write to us on that specific issue, also on the issue of air transfers of women in labour. I think Boyd Peters wasn't sure of the numbers there. That would be helpful. And also the cost of medicines, I think, is the other thing. At the moment, I have a note of as a written submission.
When you mentioned that there, and you said about an update on air transfer of women in labour, my understanding is you don't get air transport if you're in labour. So I wanted to clarify that point.
That's my understanding as well.
No, I'm just asking.
Yep,
that's a point of clarification.
Order, please, colleagues.
You don't.
The clarification we are seeking is that Dr. Peters indicated that in the event of a difficulty with road transport, those issues would be addressed by an air transfer. But the understanding around the table is that air transfer of women in labour is not something that ever happens, and therefore we need a clearer answer to the question of what happens when the road ambulance is not available.
Yes, and to be clear, I would agree with you that air transport when someone is in labour should not occur.
Yep.
So it depends on the case, the individual case and circumstances. But I accept the point that if the road is blocked, then that would provide some difficulties for the decision makers, which would be the clinician and the ambulance crew.
It's perhaps something, I'm sure it is something that's been thought about. It would be useful to have a note on what the thinking is in those unlikely but not impossible circumstances. Emma Harper.
Just a quick clarification. My understanding, it's the same issue in Stranraer versus Dumfries, that patients are very well assessed, they're risk assessed right through pregnancy, and if there is an issue, then as soon as labour happens, then they may be transferred to the appropriate place to deliver. So there are contingency and risk assessments that are put in place right throughout pregnancy these days, precisely to avoid any issues of needing intensive care when there are no intensive care beds like in Caithness.
Very good. Now, did you also, Emma Harper, have a question on performance?
Sure, yeah. It's a little bit about performance management and how the performance plans to improve the management and the lack of adequate systems prior it's hindered the delivery of some of these organisational goals, but that a new performance management improvement system will be output driven and linked to the annual operation plan. So I'm interested if the panel can provide a wee bit more detail on what the new performance management system involves and what was lacking previously that hindered the delivery of organisational goals.
Ian Stewart.
Yes. Part of our new structure is looking at the performance management framework. We understand that as a senior leadership team, we don't have full understanding all the time of where we are with the performance, and that's one thing we want to drive forward as soon as possible. That is all part of our governance review also, to ensure that our governance is appropriate. So we are working with the performance director to develop a new framework that gives us up-to-date information on a weekly basis of where we are with all our performance measures and specialties. This is a priority for our senior leadership team at the moment.
Okay, thank you. Thanks.
Thank you very much. Can I move on to the question of the provision of social health and social care through partnerships and through the two different models that operate within the area of NHS Highland? I wonder if respectively, we could hear a little about the merits of the respective systems and also the differences as they are perceived. I wonder if perhaps David Parkin and then George Morrison would like to comment on that.
Yeah, so Highland has a unique scheme of integration which has been established since 2012, prior to the legislation related to IJPs. For many people, including myself, I never knew what it was like to have an unintegrated system. But I do meet with other colleagues, other chief officers and the other integrated authorities where we're able to compare what goes on. In terms of what it means to North Highland and how integration works, I would say that it has been established for some period of time, and where teams are locally based and where provision is delivered is where our best integration takes place. So we work with multifunctional teams, integrated teams within a locality, where we would have multiple disciplines, both health and social care related. That may also include our third parties and the independent providers who would be part of that team also, and we work together to provide care for the community. Where it differs somewhat is into the sort of more formal areas, and you know, we recognise that our partnership agreement with Highland Council is due to expire in March of next year. And we're in discussion with Highland Council to be able to update the current agreement that we have. I think the discussions have been very positive with Highland Council, and they are very keen to continue the current model, recognising the success that has had. One of the significant differences between an IGB and a lead agency model is that Highland Council staff were transferred to the Health Board over this period of time. And likewise, there were health staff transferred to Highland Council. So that was a significant change in doing so. And while there are still small pockets where there's still to be resolution made, that has happened in the vast majority of the cases, and it leads to a much more integrated approach. They're the same people, they're working in the same buildings, they're working in the same teams, and certainly from my point of view, it's to the great advantage of those we care for.
Thank you very much. George Morrison.
The IGB in Argyll Butte was established in 2016 and it's been operating well. This is now into year 4. There's been significant progress. There's always been a large degree of collaboration and cooperation between health and social care services in Argyll and Butte, common for remote and rural areas. So the IGB has enabled us to build on that. There's been co-location of a number of teams. Teams are under single tiers of management now. So there's been a lot of improvement in terms of the organisational structure within the management of the delivery of health and social care services. I'm not aware of any significant concerns or issues that I would choose to flag up.
Thanks very much. Can I ask then, perhaps from a board perspective, and perhaps taking delayed discharge as an obvious measure, which of these two very different or significantly different models is most effective in dealing with the issue of delayed discharge? Ian Stewart.
We haven't, as a board, looked at delayed discharges and compared both of the health and social care in the north and the IGB in the south. We haven't done that piece of work as yet
I take it you follow the development of delayed discharge in both areas?
Yes, so with regard to delayed discharges, what we're doing is we're looking at the 6 standard practices we use for delayed discharge, and we're working on that. But also what I think is more important than delayed discharge is looking at admissions that aren't necessarily required. So if we can avoid unnecessary admissions, that saves a problem for delayed discharge on the other side. So not only are we looking at the back end of the hospital, you also have to look at the front end of the hospital too, to ensure that when people come to the front end and they're requiring i.e. social care or community care, that we put that in place at the beginning of them coming to the hospital, i.e. in the emergency department, rather than wait until they go through the hospital system and then are the delayed discharge at the end. So we're looking at the whole of the flow from pre-acute into discharge at the other end. David?
I accept the point that avoiding unnecessary admissions by definition will avoid delayed discharge at the other end of the process. I think given we've heard that the agreement with Highland Council, for example, is due up next year, I would expect you to be doing work on measuring whether the lead agency model has been more effective than the IGB model, which is used elsewhere. And I would have thought delayed discharge would be an obvious way to measure that effectiveness.
Yes, so we're working on agreements for both the North Highland and Argyll and Butte. So also next year it's not only the North Highland scheme that is due to also their Gyle and Butte. So that is also up for review come next July. So we are looking at both together, looking at performance in both of them now. And in North Highland, we've just made a joint appointment of an officer across both the council and the NHS in order to advance that over the coming months. And that's what we're looking at.
Thank you. Can I then ask David and George to comment on changes in delayed discharge in your respective areas? David Parr.
Yeah, as I mentioned earlier, capacity issues within social care with regard to both care at home and care home are a significant challenge to us across the region. That those two areas that we are working very hard on to reduce delayed discharges. For care homes in particular, there is more capacity coming on in Highland over the next 18 months, which should significantly be able to add to the necessary capacity that we need. A number of delays in hospital are related to care home. And with that, we also have the added aspect of geography within the region. It's not enough to have a capacity in a certain location, but people want to be located close to their families and their localities. And so the preference element of which care home to use is very high and has got probably a more significant impact. So care homes is one of the areas that we're looking at. Care at home we mentioned also. But one of the opportunities that we have with the current scheme of integration, as I would say in North Island, is that typically there becomes a transaction point between your acute sector, if I can describe it that way, and social care, which is at the point of discharge. What we've identified actually is that there's an area pre-discharge that we can actually focus on, and that's what we would call post-acute patients. So they may be past their most acute part of their medical care, but they're not at the point ready for discharge. And that's where we're actually trying to target to intervene so that it becomes more of a pull from the hospital rather than it be a push out from the hospital. So with the dual responsibility that we have, then it allows us to work across those boundaries which might be more difficult.
Very briefly, how does your level of delayed discharge compare with other parts of Scotland?
I would be honest and say it is not as good as other parts of Scotland. But I would suggest to you, as I said earlier, that's predominantly because of the capacity issues that we face. And those are the challenges that we're trying to overcome.
George Morrison.
In Argyll and Butte, there's a couple of hotspot areas where we've got delayed discharge issues. In Oban, Lochilphead, there's also some issues around getting patients discharged from hospitals in Glasgow and Clyde. I'm not aware we've got a significant concern in this area. My understanding is that the problems that do exist relate to specific issues relating to patients or difficulties in care home provision. These have been issues for some time and we were working to address them.
And can I ask the same question as I asked your colleague? How does Argyll and Butte delayed discharge performance compared with other parts of Scotland?
I'll acknowledge I'm not an expert in that matter, but my understanding is I think we're in the middle somewhere. I don't think we're an outlier.
Could I ask again that both North Highland and Argyll and Butte provide us with those figures for this year, but also for previous years, so that we can understand the trend? Thank you very much. Sandra White.
Well, thank you very much, Convener, and good morning, gentlemen. And I do say gentlemen, unfortunately there is no women on the board, so I'm going to ask about recruitment and retention, and perhaps the next time we'll have some recruitment of women on the board, but that's no slur against yourselves, obviously, and you're very welcome here today. You were very honest with me when I asked about the bullying situation in regard to recruitment and retention, and I do thank you for that. But you will be aware about Audit Scotland's report, which basically mentioned about the costs that recruitment and retention is one of the key issues in Audit Scotland's report. We've got 12.8 million on medical agency staff, excuse me, locum staff as well, dentistry, etc., etc. So, apart from the issues that we've already mentioned before, what are the main difficulties in recruiting for the board? And medical and dental staff in particular, because these seem to be the worst.
There's a good question. So we're working at that at the moment as a priority area, and as you say, we have quite a high locum spend. Some of that is a recruitment issue where we want to recruit into substantive posts. So we're going to have a recruitment drive to try and address that. There are some posts where it's very difficult to recruit, and I think some of it is a side effect of, if you like, the trend in medicine towards ultra-specialism. Whereas I think if our health board is an example of the opposite, what we need sometimes is generalism, where our specialists are able to do quite a variety of things, rather than dealing with one very small thing, but with a massive patient base that extends regionally and sometimes nationally. So trying to set up services in ways that deliver the services that we need, but also jobs that attract people to come and work. That's why we're looking at some of the ideas around flexible work packages, around building in research or education options into that, things that might make the jobs attractive to folks to come. So it's this is a live issue for us, and one which we're working very hard at just now.
Mm-hmm. Mr. Robertson.
Could I just add to that? It's a patchy situation in terms of recruitment. We heard about RASI and success there. I visited the Alpol medical practice, and they have no difficulty in recruiting into that particular practice, whereas further down the road in Gairloch, it's much more challenging. So it's a mixed picture. Recently, for the last 2 years, Mull has been served by a series of locums, the 3 practices in Mull. But happily, we're now moving into a situation of stability in Mull, because the Lorne and the Isles practice in Oban will be taking over the running of the 3 practices in Mull. And on a visit to Mull last week, that was very much welcomed by the community representatives I met.
Thank you. I mean, obviously, Audit Scotland's report mentioned not just the recruitment issue, but the cost issue as well in regards to locums, etc. I mean, how much is spent on recruiting basically staff by the board? Each post, how does it compare to other posts? Is it more expensive to recruit someone for your area than it is for other areas, perhaps? Or is it just...
The expense is not, I suppose, great in that there's a team of staff who are involved in recruitment. There's the cost of the advert, which will surprise some people when, to put an advert in a medical magazine costs you thousands. And that becomes, a bit more of a cost if you have to, advertise more than once. But the overall cost in the grand scheme of things of the actual recruitment process is relatively low. The big cost is in the payment of locums to do work, to provide services that you might otherwise want to be done by a substantive colleague. But that's the trend that we would like to reverse. It is a significant challenge, and the further out from Central Belt you go, the harder it can get. And hence my plea earlier around how we grow our own in the future, so that we have people who want to be in the Highlands for a variety of reasons, and that partly is professional, but might be other things as well.
Mr. Robertson.
HIE, Highlands and Islands Enterprise, is leading a piece of work on recruitment across the whole of the agencies in the Highlands and Islands, and we're running that through the Community Planning Board at present.
Chair, sorry. That was one of the questions I was going to ask, what measures can be taken, and obviously you're saying, homegrown, basically, in that respect, and what's happening, there. Would we be able to get any figures from what you're saying, Mr. Robertson, in regards to how successful it is, or how many, people have applied, or that type of thing? Because really looking at the measures to recruit rather than spending all that money in locums.
I think happy to provide that to the committee later in writing.
That's fine. Thank you.
Ryan Biddle.
Thank you. We're talking here about recruitment and retention, and I often think we get that the wrong way around. We should be talking about retention first. And we've discussed at length your issues around recruitment and how you're addressing that. It's very difficult then to increase your capacity if there's if you're pouring water into a bucket that's got a hole in the bottom of it. So how are you dealing with retention of staff? How are we looking at the staff? You're looking after the staff you already have.
So I think this goes back to our very first conversation about the culture. So what we want to ensure is that, number one, the culture in the organisation is right. We want to ensure that we have a culture within the organisation that absolutely respects all our staff, that engages with our staff, and that we value all the staff that work with us. As I always say, it doesn't matter whether you're a professor or you're a porter, every person within the organisation is really important. And without each individual person, specialist, then the organisation doesn't operate. So it's about getting that message out there to let everybody know that everybody is important, let everybody know that there is respected, that there'll be no bullying, and that as an organisation we want to be the top employer of choice in the Highlands and in Scotland. And that is one thing that we're pushing from the top to ensure that this message gets out there. But we also live that values, and we need to make sure that everybody not only knows but sees us working in that way. I think that's really important, because the culture is important to people being retained in NHS Highland, that people want to stay on an extra few years rather than retiring, that they think twice about moving to somewhere else because the Highlands is a great place to work. That's what we want to do. That's what we want the culture of that NHS Highland to be.
Good morning, panel. Has the board seen a decline in migrant workers, and if so, to what extent and what impact that is having on NHS Highland?
So at the moment we don't see that, and certainly my main issue with regard to migrant workers and any EU departure not necessarily is with NHS Highland, but it's with the wider workforce, i.e. I'm talking about care at home workers, I'm talking about care home workers. Now you may think that is external to NHS Highland, but if care homes are unable to take residents, if we aren't able to provide care at home, what happens to these patients? Well, what happens is they stay in hospital, and then it becomes a huge problem for us. So it's not necessarily migrant workers working from NHS Highland are the issue, it's migrant workers working for care homes and care at home. That's going to have a huge knock-on effect to us in NHS Highland.
It's looking increasingly likely it will be a no-deal Brexit. What impact will that have on recruitment of staff, especially in areas where there are shortages, and the general day running of NHS Highland? And what have you put in place in case this happens?
So we are working with colleagues in NHS Scotland with regard to all the EU exit procedures. That, to me, I don't think is one of the main priorities. You know, we're also looking at medicines management, we're looking at medical devices, we are looking at supplies as well, supplies of all the different requirements, you know, for running an NHS service. So recruitment is only one of maybe half a dozen priorities that we do have. As I say, it is very much working with our non-NHS employee carers that we need to ensure that we fill in the right forms to ensure that they have status to remain in the country, etc. Lloyd, will you want to speak?
No, I think your question is specifically around retention of staff, and will we lose staff if the no-deal Brexit, etc. The current indications are no. We've obviously, like all parts of the NHS these days, great reliance on EU and non-EU graduates who come and work with us. I think many were reassured by the statement from Parliament about support for people from the EU in a post-Brexit state, and we were grateful for that assurance. And when it happened, we haven't seen any signs of any exodus at present, but we must remain vigilant. And as Ian has alluded, there are sort of active meetings around how we deal with Brexit, and this will be one of the strands of those meetings, and it's beginning to look a little bit more real, as you point out today.
Thank you, Convener.
Emma Harper.
Thank you, Convener. Just to pick up on Sandra White's recruitment and retention questions, and I agree with Brian Whittle that we need to retain as well as recruit, but we also need to train. So I'm interested in maybe highlighting the ScotGem programme. So that's the Scottish Government's graduate entry to medical school. and Highlands and Islands are participating in that, as is Dumfries and Galloway in my South Scotland region. So I would like to maybe hear a wee bit more about the ScotGem from your perspective and the projections of the benefits that it will bring to maybe bring folk, not just homegrown people, but people to the Highlands and Islands region as well, because I think that looks to be quite a promising programme.
Who would like to comment on that? Ian Stewart.
So absolutely, my view is that if a person is born and brought up in the Highlands, goes to school in the Highlands, is educated in the Highlands, the chances are they will stay in the Highlands. And I think that's really important for ScotGem, because what we find in the Highlands is that if our young adults leave and go to university in the Central Belt, they will stay there and don't usually return. So the more and more training such as ScotGem that we can do in the Highlands, that will have a positive effect on attracting doctors. So it is great. I would actually like in the future to see a medical degree in the Highlands. On top of that, a medical degree in the University of the Highlands and Islands is something I think we can aspire to in years to come, and I think that will be fantastic for the local training of doctors locally in the Highlands.
Thank you very much. David Stewart.
Thank you, Convener. Can I touch on the new GP contract? As you know, there's been some debate, not least in our Petitions Committee, about the new funding formula. And some have argued in that particular committee that it underestimates the costs of care in remote and rural areas. Do you agree with that?
To Boyd Peters for that.
Yeah, it's probably a thorny question, perhaps, because I think everybody's got a slightly different opinion on it. Where NHS Highland is working with GP colleagues and GP leaders to try and implement the contract as it stands. It's a two-phase contract, and phase 2 is being approached. There is a special remote and rural working group, which I think was chaired by Prof. Sir Lewis, and that's been going, Richie, and that's been going on. So there's work going at looking at how this contract can be best placed in the remote and rural settings where the challenges are different, for sure. So it's a very active piece of work at the moment. It's very difficult to have a crystal ball and say exactly how it will play out, and what particularly, I think you asked about finances. I think people will always, in the NHS, want more money to do more. There is a finite amount of money, undoubtedly, from government. So it's optimising what is there and making sure the formula is right is part of that. And of course, it's a primary care contract in that while it's called a GP contract, much of its effect will be on the non-doctor elements of primary care provision. So it's the supportive stuff around about the function of the GP, which is being invested in, and that's all a very new thing. And the challenge of delivering that in a Gairloch or wherever, as an example, is very different to if you're doing it in Govan, where there's a greater concentration of population. So this is something that's live at the moment in Highland.
And the panel will know that this committee is doing a major inquiry into primary care, so it may be that we have you back a future date to interrogate you in more depth in this particular subject. But just looking at the ISD stats for Highland, if you look at GP performers, which is the jargon for GP partners, I believe, in the stats, is the head count is currently 251, but that compared to 304 10 years ago. So, why has there been such a change in these particular statistics?
So there's a rise in salaried doctors working in general practice, and indeed I saw out the last bits of my GP career as a salaried GP. So I would have been one of the numbers that disappeared, but I was still actively seeing patients. So as ever, statistics represent only a certain thing. Those that run the business are usually the partners and take the responsibility, but nowadays the business modelling, certainly in the last decade, prior to the new contract, has lent very heavily towards salaried doctors, and indeed many of the doctors wanting to work in general practice had a preference to be salaried rather than to be actually running the whole business and being responsible with the financial risk involved.
As you pointed out, Mr. Peters, there's a debate around this issue, but certainly my own experience, and colleagues will have been to similar receptions. I went to a reception at Royal College of GPs just before the recess, and certainly they had very strong representation to make on that. And certainly since we've issued the call for evidence for primary care certainly I've been contacted, and I've visited GPs in Nairn area at their request, and out with your area in Elgin and in Shetland. And I have to say it's been a pretty similar story, that GPs were quite concerned about aspects of the contract. It's not universally so. I think the use of other health professionals is broadly welcomed, and I think there's some issues over the health board's assumption that it will take over the ownership of premises in the longer term, but maybe that's more an issue for our inquiry than today. But I just wanted to flag up there certainly is some issues. But Mr. Peters, your issue around numbers, the reason for the reduction in your view is purely because of more salaried, but the actual number of GPs are the same. Is that the point that you're...
Well, I can't say if they're exactly the same, but I think the number that you've quoted is performers or partners. Partners,
yes.
Is that right?
GP partners.
Partners, yeah. And we're seeing a trend that there are fewer partners in running practices and more salaried, and that's a trend that's playing out in most places.
Perhaps, and I'm sure the convener is going to mention this if I read his mind, is that perhaps we could get some accurate statistics, because obviously what I'm quoting to you is the ISD Scotland survey, so that is normally the independent assessment of numbers in the health service in Highland. So if you've got a different interpretation of these stats, we need to know about that.
Helpful. I want to finish in leadership, but and the composition of the board. But just before I do, just to come back on the issue of maternity and Caithness, the figures I've seen from the Caithness Health Action Team suggest that 90% of mothers from Caithness are sent to Raigmore to give birth, and that there's a very high proportion of those births are induced births. Those seem surprising levels of risk assessment, and I wonder if we could have a response to that.
Yeah, so it's individual patient care, and it's individual patient choice with the choice. So there's no scent in it. Nobody's sent, but a specialist and a midwife will be involved in a person's care when they start the journey of pregnancy. They will talk through the risks that apply to that individual's health and their individual pregnancy, and the decision is then made jointly, so that there is very much under realistic medicine a maternal preference stated. The clinician will state what will carry the right amount of risk in that given situation. We are seeing that there are a lot of prospective mothers who will choose the safest option, one where they go to a hospital which will have a neonatal intensive care unit, for instance, and some of the other attendant services that may not otherwise be available to them. But there are still, the community-led sort of unit is available to them. The same in other parts of the Highland. There are a number of community-led, midwifery-led units. And so it's difficult, therefore. It's not a board decision. We aren't making any influence on the individual conversations. That's between a consultant obstetrician and two parents who are wanting to safeguard the well-being of their child.
Okay, David Park.
Just to add some numbers to what Boyd was referring to. So we have other community maternity units across Highland, and indeed in Argyll and Bute. In Skye and Fort William also, typically we see 10 to 12% of those are local births. So the model in Caithness is very similar to what we're seeing in these other community maternity units.
That's very helpful. Ian Stewart.
We have great facilities in the different community maternity units and great midwives in all the areas, not only in Raigmore. So if a mother is on a green pathway, we'd absolutely say that they were in a great place to stay in Caithness General and the other maternity units. They'll be cared for in all these places very well.
Okay. Emma Harper, briefly.
It is just a brief question. It's like sometimes the first child requires maybe an intervention in Raigmore, for instance, but if you had a safe delivery with the first child, so you're para 2, you might then choose to have a community midwifery-led delivery. So it all depends on the risk assessment and whether it's the first, second, third child. Yeah.
Okay, I think that's
very much offered. And it is then ultimately is for the mother and the clinician to come to a decision about what would be best and what they would prefer. And it's very much preference and as well as risk management.
Okay, thank you very much. Leadership has been a recurrent theme in our engagement with health boards and with IGBs and indeed in our budget reports on integration and so on. Casting back to the point where you were looking at finance and planning ahead, and you talked about the importance of PwC coming in to provide some expertise. I wonder if you could comment on that. Does that reflect a lack of capacity within the board itself? Is there an issue around the kind of expertise you need in order to provide the kind of leadership that Highland clearly needs going forward? Boyd Robertson.
I think it's a recognition of the fact that we were escalated to level 4 and required considerable external input. And Ian has already made reference to the recent appointments that have been made since he and I joined the board, namely the new Director of Communications, new Director of HR, ongoing recruitment of a Director of Finance. These are measures to be put in place to address that deficiency that there was in the organisation. I was quite taken aback when I joined the organisation that we had an HR director for an organisation of 10,500 employees who was part-time, and that has been addressed. But we recognise that we can't address the financial turnaround, especially in the absence of a finance director, without external support, and we were very grateful to the Scottish Government for the support offered through PwC and the establishment of PMO, and also we had a turnaround director installed for a period of 6 months, and all of that has been very helpful in addressing the financial turnaround issues.
Thank you very much. Edward Mountain.
Okay, thank you very much, Convener. And I'd like to say at the outset that Boyd and Ian, you've worked particularly hard to cultivate a relationship which I welcome with the MSPs. Just, Boyd, a question for you. It's 2 questions. The first part is, if you look at an organisation, you look at the management, see how it's going. There was a string of resignations of board directors, which indicated to everyone outside the board there was a problem. In fact, what was interesting is there was a letter written by the executive directors on the board to the non-executive directors telling them that there wasn't a problem with the chairman and the chief executive, which went contrary to what the other board members, the non-exec board members, felt. Do you think the problem within the board should have been picked up earlier because the red flags were there in the fact that so many non-executive board members had stepped down?
I wouldn't wish to comment directly on the situation before I came into post on the 1st of March, except to observe that I did notice that there was an exceptional level of departures from the board in 2017, I think it was. And I think that was part of the failure to grapple properly with the bullying issue within the board at that time. And I have, since joining the board in March, I have attempted very deliberately to set a new tone and tenor in the organisation, as has Ian as chief executive, and I think that that's very important. And we are about to appoint a vice chair. We're just waiting for appointment by the approval by the cabinet secretary to that, and that's a very important part of the organisation going forward. I think there's still a lot to be done on the governance front. We are working on that extensively. John Brown, who is chair of Greater Glasgow, is very helpful in that regard. He's mentoring me in my role here, and that's very helpful to me. But he, as you know, produced the Good Governance report, which was based on his analysis of governance in the Highland board area, which showed considerable deficiencies in practice at that time. And we are in the process of addressing that. We've had a series of board workshops we've engaged NES in that regard, and we've now had board workshops on finance, on risk register. We've had one recently on board roles and responsibilities and team building, one on induction, and of course the Sturrock one last week, chaired by John Deffenbaugh of the NSS. So we are on a journey to address the deficiencies that I think it's fair to say that we inherited.
So the second question is perhaps easier because you partly answered it, but I mean anyone looking from the outside that saw that level of resignations in board members would have not only red flagged the issue, they would have gone straight in and found out what the problem was. But taking it forward, I mean, non-executive board members bring a huge amount to the organisation and can bring a huge amount to the organisation. Will you be setting up annual reviews to allow those board members to feed back to the board executive members to allow them to say how they're feeling the board is progressing? Because if there isn't that openness, I'm not sure they'll be able to deliver the full potential they have to offer.
Yes, we're looking at a range of different actions in that regard. For instance, that each non-executive member is teamed up with a board executive member and shadows that role and brings information, two-way information dialogue. Also, we have annual appraisals of board members, which gives them an opportunity to tell me how they feel. We have the iMatter survey, which was already mentioned, and other instruments are planned as well, such as having the chairs of each of our committees meeting as a group, something that's been in abeyance for a period of time. So we're looking at a range of measures to address that very situation.
Thank you. Thank you.
Thank you very much. And can I say thank you to all of our witnesses for your attendance this morning. There are a number of items on which you've agreed to provide further written evidence. I won't rehearse them all here. I'm sure you're fully aware of what those are and look forward to hearing that, receiving that further evidence. Thank you very much. We will now suspend for 2 minutes and then move into private session thereafter.